Now we're going to talk about some assessment of the respiratory system and some basic properties of the respiratory system and basic symptoms of respiratory disease. So, one of the things that a lot of students find confusing about this chapter and the cardiovascular chapter is that a lot of the diseases have the same symptoms. So, how do you tell them apart? We're going to talk when we talk about the individual things about how you tell them apart. But we're also going to classify the different disorders into categories to help you tell them apart. So the basic categories are obstructive pulmonary disease, where you have trouble breathing out, restrictive pulmonary disease, where you have trouble breathing in, and infectious pulmonary disease, where there's an infectious agent involved. So naturally, the treatments are going to be different for those things. And the assessment, though, is going to be relatively the same. So by the end of this lecture, you should be able to explain and discuss data collection for the respiratory system, tests and measures for respiratory conditions, and general signs, symptoms, and effects of pulmonary and respiratory disease. So this applies to pretty much all pulmonary and respiratory disorders. The normal respiratory rates we count in breaths per minute during times of quiet respiration. So when you're taking someone's respiratory rate, you usually don't tell them you're taking it because, interestingly enough, respiratory rate is it's the only vital sign that we can change voluntarily. We can voluntarily breathe faster or voluntarily breathe slower. So if you do it when somebody's not paying attention or when they don't know you're taking it, you get a more resting breaths per minute. Another interesting thing about respiratory rates, there was a study that came out in 2022, and I want to say it was in the Journal of the AMA, but I'll get that reference for you, that said that respiratory rate is the most commonly missed or not taken vital sign, even in patients with respiratory diagnoses. Kind of interesting. So, with newborns, their normal respiratory rates are way higher. So they're just learning how to breathe at this point. They're developing. And in adults, the respiratory rate is lower than in an infant respiratory rate. So and also the babies have those itty bitty little lungs. They're just pumping out little air. So when you do your CPR and you learn infant CPR, you're not blowing a huge amount into their tiny little lungs. You're just doing puffs of air into their tiny little lungs. So they have a higher rate. A 3-year-old has a slightly lower rate, but they still have higher metabolic demands. A 16-year-old is starting to transition to adult rates. And then the adult norms are 12 to 20 beats per minute. That's sort of our baseline. So normal breathing, we get rhythmic chest and abdomen movement. Your shoulders are level. You're not using a lot of accessory muscles. There are no signs of distress or difficulty breathing, which that's what we really want. Common respiratory signs and symptoms include, and probably you've maybe seen some of these, maybe not all of them. Cough is a very common symptom of a lot of different respiratory disorders. A cough can be productive or non-productive, meaning are you coughing stuff up or are you not coughing stuff up? It might indicate irritation, inflammation, or obstruction, and the effectiveness of the cough depends on respiratory muscle strength. So if somebody has some kind of weakness because of a neurological injury or some other reason, we might need to train them to do an assisted cough. So dyspnea is the subjective feeling of breathlessness. You feel out of breath. The patient feels unable to inhale enough air. Orthopnea is dyspnea when you're lying flat. So people feel dyspnea when lying flat, and then when they sit up, they feel better. Sometimes we'll talk about the number of pillows it takes to be comfortable. And so we'll say 3-pillow orthopnea, meaning when they're lying flat, they have dyspnea, but they have to be up on 3 pillows in order to feel comfortable. So anything with PNEA at the end has to do with breathing. So apnea, dyspnea, orthopnea, it's all has to do with breathing. So tachypnea is an altered breathing rate that is faster than expected. Bradypnea, hard word to say, is slower than expected. So you consider the age appropriate norms. So when we look back on here, if somebody's relaxed breathing rate is greater than 20 beats per minute, that's tachypnea. If it's lower than 12 beats per minute, that's bradypnea. Okay. Cyanosis is you're blue. Cyan is the word for blue. So it's a condition of being blue. So it means you're not getting enough oxygen. Usually you see it in the mucous membranes or in the lips, especially the lining of the lips or the lining of the eyes. Um, Peripherally, you might see it in the nail beds or the extremities. It indicates poor oxygenation. And if you've got your oxygenation is so poor that you're starting to turn blue, that's bad. So something needs to be done at this point. Chest pain can be a symptom of cardiac disorders, but it can also be a symptom of respiratory disorders. So chest pain may radiate to arm or shoulder, and you need to take note of the location and quality. And that's a red flag right there. If somebody's having chest pain, we don't want to continue therapy with them. Clubbing is that happens at your fingertips, and there's a good picture in the textbook where the fingernail angle flattens to greater than 180 degrees. So it's not it's sort of almost bowed out, if you want to think of it that way. It's associated with chronic pulmonary and cardiac conditions, but it can be hereditary. So if people have clubbing without dyspnea or cyanosis, it might not be, and they don't have a respiratory diagnosis. It just their fingers just may be that way. But if they develop it over time, then it might be because of a respiratory problem. So the diagnostic testing that we're going to do that, well, we're not going to do the diagnostic testing that they do with respiratory things. Spirometry, like I was saying, when you breathe into the spirometer, it's a pulmonary function test, is also what it's called. It tests pulmonary volumes and airflow times. A lot of times to determine a diagnosis of asthma, they'll use spirometry and other diagnoses. Arterial blood gas determination checks oxygen, carbon dioxide, and bicarbonate levels, as well as serum pH. And that is often they're trying to determine if you're in respiratory acidosis or alkalosis or metabolic acidosis or alkalosis, which we'll talk about later. But basically, if it's not respiratory, it's metabolic. Oximetry measures O2 saturation, and we've done that in lab with a pulse oximeter. Exercise tolerance testing for patients with chronic pulmonary disease, they're usually testing your breathing while you're walking or running on a treadmill or riding a stationary bike, something like that. For imaging, they're going to do radiography, like chest x-ray. It's helpful in evaluating tumors, evaluating infections like tuberculosis, and pneumonia. Bronchoscopy is where they put a scope, anything with scopy on the end, they put a scope down your bronchioles and they can perform a biopsy through the scope, or they can check with the camera of the scope the site of any lesion or bleeding. And a lot of times that's used in detecting doing biopsies for tumors to tell if they're cancerous or other sorts of lesions in the lungs. Culture and sensitivity tests are done to see if there's pathogens in your sputum, the stuff you cough up out of your lungs. There's a really neat little sputum chart that you can tell what's going on based on somebody's sputum. So when you're working in the hospital and somebody coughs something up, don't throw it away, save it for the nurse. They want to see that. So the sensitivity test determines the antimicrobial sensitivity of the pathogen, because there's no point in giving someone an antibiotic if their pathogen is not sensitive to it, right? So when we're assessing, or the PT is assessing a respiratory patient, we're going to do a subjective assessment. We're going to ask the patient if they have any shortness of breath, dyspnea, fatigue, energy levels, and activity tolerance. How long can they do something? How long can they walk or stand or something before they have to rest? Any pain, the location, quality, intensity of the pain, and history of previous respiratory conditions. So in the objective assessment, of course, we're going to take their respiratory rate. We're going to count the breaths per minute. We're going to observe their chest movement. We're going to listen to their breath sounds with a stethoscope, which is called auscultation, which we'll do in lab next fall when we're talking about pulmonary rehab. We're going to look at any changes in chest shape, and I'll go over some different changes that you might see in chest shape. And then, of course, your good old rest of your vital signs, heart rate, blood pressure, O2 sats. We're going to test all that stuff for our objective data. So when we start talking about abnormal breathing patterns, we already talked about dyspnea, which is difficulty breathing, and it's a subjective feeling of being short of breath. Where and then the respiratory rate is going to reveal tachypnea or bradypnea. We're going to look when we're looking at chest excursion, we're kind of looking at the normal use of the diaphragm, or are they using some accessory muscles like SCM or scalenes or pectorals or trapezius to drag the ribs up and get more air in? The apnea is the absence of breathing. So pnea with an A on the front of it. Absence of breathing. So when we talk about obstructive sleep apnea, it's you stop breathing while you're sleeping. Hypopnea is shallow breathing with a reduced airflow. Hyperpnea is fast, deep breathing, and that's normal during exercise. So, say you're running and you're fast, deep breathing, that's normal. So, some of these are normal, some of these are not normal. Paradoxical breathing is normally the rib cage moves out when you inhale. So, it moves out on inspiration and it moves back on expiration. But if part of the rib cage collapses inward during inspiration, that's called paradoxical breathing. And it's seen when you have a flail chest. And flail chest is when you have enough ribs broken that part of the rib cage isn't working with the rest of the rib cage, and that's never good. Usually, a traumatic injury is the cause of that. Kane-Stokes breathing is quick breaths followed by periods of apnea, and it's associated with brain or heart damage or total organ failure. So that's never good. We just don't want that. So usually, sometimes Kane-Stokes and buyouts are used interchangeably. Buyouts is a group of shallow breaths with irregular apnea and also caused by brain damage or an opioid overdose. Usually, if you're in Kane-Stokes or buyouts breathing, that's not good. You're on your last few breaths in that case. So an ataxic breathing pattern is an uncoordinated breathing pattern. So anytime we talk about ataxia, if we talk about an ataxic gait, it's an uncoordinated gait. If we talk about ataxic arm movements, it's uncoordinated arm movements. So same thing with breathing. An ataxic breath pattern is an uncoordinated breathing pattern. So the too small breathing is deep labored gasping, and it's usually associated with metabolic acidosis. So we're trying to, our body's not great when we're in metabolic acidosis. We'll talk about all the different causes of metabolic acidosis. It'll be so fun. But respiratory acidosis is caused by respiratory dysfunction. Metabolic acidosis is everything else. It's not respiratory dysfunction. So the abnormal breathing patterns, that's something, if we notice one of these, we're going to make note of that. So there's some different breath sounds that you might hear when you are auscultating with a stethoscope. Crackles, which are sometimes also known as rails. They're fine rattling or crackling sounds like Rice Krispies sort of sounds associated with the alveoli popping open. If you have fluid in your lungs or excess mucus or atelectasis, where the alveoli actually collapse and they have to be forced open, you might get that crackle sound. And it's the sound that you hear as the air is moving through secretions or opening alveoli in the lungs. And this is not a normal sound. Wheezing is a coarse whistling sound on inspiration or expiration, and it usually indicates bronchial tree obstruction. So it might be obstruction by inflammation or excess thick tenacious mucus, like with asthma attacks or cystic fibrosis. You might get that wheezing. Stridor is a high-pitched sound, and if you get a chance, go on YouTube and look up Stridor. Look up any of these, and you'll hear, and man, it's crazy. So Stridor is also sometimes it's associated with croup, and if you've ever heard an infant with croup, it's a scary sound. It's not good. So croup, epiglottitis, which is an inflammation of the epiglottis, basically, or if there's a foreign body stuck in your airway, or there's some kind of laryngeal or bronchial obstruction. And stridor is not a good sound, and you can usually hear that without a stethoscope. Pleural rub is a squeaking sound while you're auscultating, and it's associated with pleural effusion, which is fluid in the lungs, and it indicates pleural membrane irritation. If you don't hear any breath sound, something's going on. Either the lung is collapsed or it's obstructed to the point where air's not moving in and out of it. So it might indicate atelectasis, which is collapse of the alveoli, or a pneumothorax, which is basically a punctured lung or a collapsed lung. So that's not a good thing either. So for one of the other things that you may or may not be exposed to before we talk about chest excursion is sputum. So sputum is usually, it's the stuff you cough up out of your lungs, sometimes also called phlegm. It's assessed for how much you produce. So if you produce a copious amount of sputum, you'll make note of that. Color and consistency. Normal sputum, when you cough up phlegm, it's just clear and translucent. That's normal. If anything is green, if your sputum is green or purulent, has pus in it, that means you have an infection. So with pneumonia, you might cough up green sputum. Anytime green always means a bacterial infection. I'll just tell you that, unless it's your gallbladder. And everything else, it means bacterial infection. Blood tinged sputum, or it's also known as hemoptysis, which is coughing up blood. It's associated with tuberculosis, lung cancer, or irritated pulmonary structures. Sometimes if the sputum has black flecks in it, it could be carbon particles in the sputum. And I don't know where you're going to get those unless you work in a lung a coal mine or you smoke. I guess that's where you're going to get it. A lot of smokers cough up gray sputum. Fun. And if you work in a coal mine, you're going to be coughing up black sputum. So your heart rate usually increases in association with pulmonary disorders. It's a compensatory strategy for the body to get more oxygen. And so your heart rate goes up to get the oxygen moving around more. If you're still not getting oxygen in, it ultimately is self-defeating. It doesn't really work. So we're going to measure chest excursion. One way to do it is with a tape measure. So you put a tape measure around the sixth rib level, and you measure from maximal expiration to maximal inspiration. If what you want to have is at least an inch or 2.5 centimeters of expansion. If you have less than that, it indicates a restrictive lung disease. And remember, restrictive lung diseases make it difficult to inhale. So if you have less than an inch or 2.5 centimeters, then that can be indicative of restrictive lung disease. An alternative method of measuring chest excursion is you place your hands at the T9, T10 level, and kind of put your thumbs about 3 to 5 centimeters apart. Or they should, when the patient takes a deep breath, the thumb should move about 3 to 5 centimeters apart, and the movement should be smooth and symmetrical. It shouldn't be one side moves and then the other side moves or anything like that. So a chest expansion test is commonly done, and a lot of times they do it manually with their hands like that. There's another test that's called tactile fremitus. The patient says 99, 99, 99. I don't know where they came up with that, but the clinician assesses the vibrations on the posterior thorax. So they put their hands on the posterior thorax, and if you feel vibrations when the patient is saying 99, it can help identify obstruction or pulmonary edema. Interesting, right? So chest shape abnormalities, there are some of them are just they don't really affect your breathing, so that's when they say they're primarily cosmetic, but others can significantly impact respiratory and cardiac function. So chest shape abnormalities, the barrel chest, it extends in an anterior posterior direction, so the sternum appears raised. And it causes like a circular or barrel-shaped appearance. You see that in COPD or cystic fibrosis, which are both obstructive diseases, and you have trouble breathing out. And you get air trapping, and that's kind of what causes that barrel chest. Flared ribs, it's an inferior rib widening. Long-term lower lobe distension, so that's another air trapping thing. So COPD or cystic fibrosis, and that you can see how air trapping would cause your ribs to flare out. Pectus carinatum, it's pigeon chest or pigeon breast, sometimes they call it, where the sternum protrudes, and it's associated with some genetic conditions, but it doesn't really have very much effect on breathing. And then funnel chest is sort of the opposite, pectus excavatum, where the sternum is depressed and it's associated with some genetic syndromes. And that can severely affect function because the sternum actually has to lift a little bit while you're breathing to help expand the chest. So if you note a chest shape abnormality, maybe you know what it's associated with and maybe you don't, but that's a good thing to report. It's a good thing to document. So the assessment skills that we really need to know as PTAs, we need to be able to monitor respiratory rate and pattern during treatment. That's super important. We need to be able to observe for signs of respiratory distress, like is the person turning blue? Are they turning red? The colors that you note in respiratory distress are red, white, and blue. Somebody is red, white, or blue, and those aren't their normal colors. I don't know that anybody's regularly red or blue, but yeah, I'm not going to rule it out. But if they're red, white, or blue, then you probably need to stop or modify your treatment. If they're visibly having difficulty breathing, or if they report to you that they feel short of breath, that might indicate that you need to modify or stop treatment. You want to document those objective findings accurately, and you want to communicate any concerns to the supervising PT, and maybe sometimes the patient's physician. So when to stop treatment, if somebody is having severe dyspnea or respiratory distress, if they have central around the mouth or peripheral around the fingers and toes, cyanosis, chest pain with respiratory symptoms, significant changes in breathing pattern, or the patient reports severe shortness of breath, stop. Don't make them do anything. So we always want to prioritize patient safety and communicate any concerns with the supervising PT immediately. So that's a big red flag. If somebody's blue or has significant changes in their breathing pattern, if they're red, white, or blue, might be a good time to stop treatment.